kind introduction and welcome everyone. We have had to face some delay, so now we shall start with the topic. Our topic for today is in the domain of abdominal emergencies, right? And in this, to discuss today acute abdomen. Why acute abdomen? Because acute abdomen is one of the most common emergency or common case which you shall encounter in emergency and surgery and in OPD. As a surgeon, this is one of the most common problems and disease by which the patient will come to you. What is acute abdomen? First thing you have to know, it is a severe pain lasting for at least 2 hours, but not more than 5 days, with which the patient has come to you. There are two types of patients in the acute abdomen scenario. Number one, non-urgent cases, and second is urgent cases. Non-urgent cases means where you can treat the patient on the OPD, do some basic investigations, and send him back home. Emergent and urgent cases are those who need admission and or immediate surgery or immediate intervention. Now, basically, as an undergraduate, you must understand what are the types of pain in the abdomen. It can be visceral, parietal, or referred. It can be on the referred pain is the one pain in which there is, because of the common dermatome, there is the disease is at one side, but the pain is at a different side. And the difference is the area between the two is pain free. Whereas in radiation, you have pain all along the pathway. Here itself, though not in the slide, it is important to tell you that the pain is basically of two types. First is colicky pain, and second is continuous pain. Now, what is colicky pain? Colicky pain is a pain of sudden origin, severe, sharp, shooting, and it reaches a very fast crescendo. That means it attains the peak very fast, and then it slowly goes down. The decrescendo is long. Now, when do we have this colicky pain? This will happen in tubular organs wherever there is peristalsis, like ureter, like CBD, like intestine. Now, why it happens? Because whenever there is obstruction in any tubular structure, the general tendency of the body is to expel that out or to overcome the obstruction. In this, by this, the peristalsis is increased many a times, and the pain is because of that. There are certain causes. One, just remember that left shoulder, if the pain is there is referred pain or radiation of the pain, you must get alert for cardiac conditions. Right shoulders, if you have to remember one is, it will be abscess also causes sharp localized pain with normal peristalsis. Suppose that means if you have an abscess in the abdominal cavity, the peristalsis will be normal. Whereas if there is perforation or obstruction, then the peristalsis will be abnormal depending on the situation. Now, as I told you, there you must remember that acute abdomen does not always necessarily mean that it will be a surgical causes. at least you must remember the three distinct groups which can have, which can present as an acute abdomen, like endocrine and metabolic causes, hematological causes, toxins and drugs. These are the non-surgical causes. Now, the surgical causes of acute abdomen. These are widespread causes. But usually we take only those entities in this acute abdomen domain which are non-traumatic, right? So any of the cause in which there is hemorrhage, like fistula in aortic vascular graft, arteriovenous malformation, bleeding gastrointestinal diverticulum, hemorrhagic pancreatitis. These are those causes, especially ruptured ectopic pregnancy, spontaneous splenic rupture, in which you will have hemorrhage. With acute abdomen, if you have hemorrhage, then these are the causes which you have to think. Meaning thereby, whenever in a patient of acute abdomen, you find that there is unexplained and sudden anemia, then you should be very cautious and think of these causes. Whereas the other group is of infection. Infection can occur in any of the abdominal organ. Now, how you will differentiate between hemorrhagic and infection? In hemorrhage, I told you, like there will be features of hemorrhage. There can be hemoperitoneum, but the most important will be unexplained sudden anemia. Whereas in infection, there will be no sudden anemia. There will be features of infection like fever and features of toxicity. Now, the other causes ischemia. Ischemia, most of the times, which you get is ovarian torsion, strangulated hernia, or testicular torsion. In this, the pain is sudden. Initially, when there is no gangrene, then you will have some difficulty in differentiating this with the other causes. The other group is obstruction. Obstruction. This is one of the most important causes. Like obstruction, you can have anywhere from the gastric outlet obstruction till the last of the large bowel. The most important one is cecal volvulus, intussusception, small bowel obstruction. In obstruction, what you will have? You will have distension of abdomen. Then you will have paresthesis, patient is not passing flatus. Then perforation also can happen from stomach to the large intestine. But the most common parts of perforation are duodenum, terminal part of ileum, jejunum, stomach. Patient will have peritonitis, distended abdomen, tenderness, rigidity, guarding, and rebound tenderness. Rebound tenderness, what happens is within. Now, one thing, this is the areas which are being shown. I have taken this diagram to make you understand whatever is written on this. Apart from that, that these are the 9 parts. So whenever there is pain in any of the part, especially pain, then you must first what are the underneath organs, because the pain will mostly originate from the underlying organ. That means the etiology will be in the underlying organ. So if you know what are the underlying organs, then it will be easy for you to evaluate what can be the cause of this. Whereas in peptic ulcer disease or gastritis, eating, just taking something will relieve the pain. Patient with peritonitis will avoid any activity that stretches or moves the abdomen. That means if he will try to remain in one posture. And if the pain increases on change of posture or stretching, then you must suspect peritonitis. Then the other features like associated symptoms, as I told you, nausea, vomiting, constipation, diarrhea. These will give you some idea of altered bowel habits, or the etiology lies inside the intestine. Pruritus can be in case of jaundice. Melena, upper GI bleed. Hematogesia, large bowel bleed. And hematuria in the cases of renal symptoms, genitourinary. Vomiting, if there is only vomiting, then the chances of non-surgical conditions are more. Whereas if there is a surgical cause, pain will appear first, vomiting will appear afterwards. Why? Because if there is some obstruction or perforation, pain will start immediately, whereas vomiting will occur after some time. Associated symptoms, constipation. I told you, if there is absolute constipation, then no bowel will pass, no stool will be passed, no flatus will be passed. Whereas in relative obstruction, patient will say he's passing flatus. Then you must understand that this is not a case of complete obstruction. This is important. Why? Because if patient has complete obstruction, then the chances of surgical intervention are much more. Whereas if the obstruction is not complete, then there are chances that conservative trial will succeed. Other things which you have to ask in the past history or your examination: what is the medication the patient is taking, any history of prior surgery, abdominal scars, condition of the skin. These you have to also take in the part of your clinical evaluation. Now, some medications are important to know because they per se can cause pain in abdomen, mimicking acute abdomen. The most important cause of them is high dose narcotics, anticoagulant drugs, cocaine, or other related drugs, right? These can cause cardiac or intestinal ischemia, but with this, severe hypertension will be associated. If you have a woman, young lady in her menstrual age, you have to also rule out ectopic pregnancy, pelvic inflammatory disease, and severe endometriosis. Now, on examination, after the history, when you have taken the history of chief complaints, history of present illness, negative history, past history, treatment history, then you will proceed for your examination. What are the main headings of examination? inspection, palpation, percussion, auscultation, measurements, and hernial sites. These are the six which are to be under these six heads. You have to do your examination. See, many a times you can assess the patient on not local examination, only on general physical examination. How the patient enters, how much pain he has, what posture he is making. So, whenever the patient is entering your OPD or emergency room, you must start observing the patient from the point of entry. Then, in inspection, the first things which you have to see is whether the shape is normal or not. What is the normal shape? It is a scaphoid shape. Now, then you have to see whether there is distension. If distension is there, whether the distension is localized or generalized. Then you have to see the position of the umbilicus. Then you have to see if there is any visible peristalsis. Then you have to see if there are any scar marks or any visible veins on that. You have to see the hernial sites. Then you will do palpation. Palpation may first you will do the superficial palpation of all the 9 parts of the abdomen. Then you will do deep palpation. You will try to see whether there is any organ is enlarged. You will try to see whether there is any tenderness. You will try to see rigidity. You will try to see guarding. You will try to see rebound tenderness. Right? You will see all these things. If ascites is there, you will see shifting dullness, or if there is huge ascites, you will do fluid fill. Percussion. Percussion will give you many informations, like if there is a enlargement of liver, if there is a gallbladder lump, then the percussion will help you decide the liver span, and with this you can decide whether the liver is pushed down or liver is in fact enlarged. Percussion, you can also come to know whether there is the distension is basically gaseous or not. This I have told you, superficial palpation and deep palpation. Now, as an undergraduate, you must know how to differentiate between voluntary and involuntary guarding. Voluntary means when the patient himself is not letting you to do deep palpation. And the second is involuntary. Even the patient is not stopping you, but the abdominal condition is such that there is involuntary guarding. See, voluntary guarding is because patient has pain in the abdomen. And when you put your hand, he is afraid, he is scared that when you will palpate, then there will be pain with the patient. So, to the easiest way to do differentiate between the two is you try to divert the attention of the patient. Someone else comes and starts talking to the patient regarding some other incidents or his history or something else, so that his attention is diverted from your hand. And then during that diversion, you will try to palpate, deep palpation. If it is voluntary, then there will be no guarding. But if it is involuntary, it will be present even after the attention has been diverted. So there are lots of signs. These are specific signs which are enumerated here. If you are preparing for your NEET examinations or something like that, then you need to know these tests, and it will depend upon your caliber how many you can remember. But these are important for if you are going for good marks or you are going for your NEET examination, and each test has to be understood separately. I have given you a list so that you can know that there are many specific tests which are a part of abdominal examination, and like you can say Rosling sign, eh? So pain at McBurney point, that will make you suspect there is appendicitis, right? So these are the tests which will give you a specific idea for a specific disease. You must go through them and try to remember as much as possible. Now, I told you the first thing in the OPD or the emergency, what you do is try to know whether this is an urgent cause of acute abdomen or non-urgent. So, for that, first and most important is clinical evaluation, which we have done. Then the second is blood investigations, basic blood investigations, right? Like if there is WBC is increased, you will suspect for infection. If bilirubin is increased and there is pain, you will suspect obstructive jaundice. If amylase and lipase increased, you will suspect pancreatitis. If electrolytes are disturbed, then you will suspect paralytic ileus. So these are the tests. Now imaging. Imaging is very important. First thing is the old time tested X-ray. X-ray will give you basically an idea of perforation and obstruction. Then ultrasound. Ultrasound will give you an idea of obstruction, ascites, lymphadenopathy, stone in the gallbladder, stone in the CBD, stone in the ureter. Basically, stone diseases that will give a better idea. Then, if the ultrasound is not fixing the diagnosis, then the test of choice is CT scan of abdomen. See, there are certain diseases like malignancy, like adhesions, which cannot be diagnosed without a CT scan. Then diagnostic laparoscopy is if you want to have a total overview of that, and or if even if the CT scan is not able to settle the diagnosis, then he will go for diagnostic laparoscopy. X-ray, the X-ray you don't need to remember a lot, but the one thing you must remember is that if you take an plain X-ray in the standing position with both domes of diaphragm, then there will be air on the below the right diaphragm. If there is, then you must be reasonably sure that it is hollow viscous perforation. But just remember that the same is not true on the left side because in the stomach there is some gas. So don't be confused on the side of the X-ray. If it was only on the right side, then it is perforation. If it is on the left side, it will be gas in the stomach. Right? Obstruction, as I told you, two things you can find out. Number one, perforation, that is gas under the right side of diaphragm. And second, you in obstruction, you will have multiple air and fluid levels. How are air and fluid level created? What is this? See, there is, whenever there is obstruction, there fluid accumulates there, and then there is fermentation because of the secondary infection with bacteria, which creates more air. Number one. Number two, you are digesting, you are taking air through your oral cavity also, right? ingesting air. So that usually passes with the intestinal contents. But if there is obstruction, the ingested air will also accumulate. So these accumulate because of the fermentation and ingested air in the fluid. So you have multiple air and fluid levels. Whereas if it is in the large bowel, then you will have distended peripheral bowel loops. There are certain other things also in the X-ray. If you can remember that, then it will be helpful for you. Hostel markings from the Taenia coli will differentiate you from small intestine and colonic gas. Other things which can be diagnosed on an X-ray, if there is a good quality X-ray, which already we have these days because of the introduction of digital X-rays, it's cecal volvulus, sigmoid volvulus. These have specific tests, cecal volvulus, comma-shaped loop, because it is pulled at one point. Sigmoid volvulus, bent inner tube or coffee bean sign, when the apex of the dilated loop points into the right upper quadrant. These are specific tests which can be diagnosed on plain X-ray. Then what is diagnostic peritoneal lavage? See, nowadays, after the invent of good ultrasound and all, this is not needed. But as an undergraduate, you must know, this is when you have peritonitis. This is when you want to differentiate with what is the content in the peritoneum which is causing peritonitis, whether it is hemoperitoneum, whether it is bile there, or whether it is fecal matter. This you want to know, whether there is pus. So it is a simple test, especially for peripheries where you don't have a well settled ultrasound. So you do these tests and you will come to know what is the content. So now at the end of this, you know, you will have to make a differential diagnosis. Differential diagnosis means in the present clinical scenario, what are the possible diseases which can mimic this clinical scenario. Then you rule out some conditions, you ask negative questions, and then you make a provisional diagnosis. Then, after the help of investigations, you make a definitive diagnosis. Right? So, there are certain things which are preferred, but as undergraduate, I would like to tell you that the first line of investigation has to be always ultrasound and X-ray. CT scan and MRI and rest only if X-ray and ultrasound is not able to settle the diagnosis. Now there is some age distribution also in the causes of this, right? So intussusception, you can go through the first column and the last column. Last column is the diseases of the adults. First column is basically the diseases of neonate or children. And these are in elderly patients. What are the causes? As I told you, peptic ulcer disease, GI bleed, appendicitis, anything. Differential diagnosis in an oncology patient, most common is tumor, either in the large bowel, ileocecal region, or anywhere. Thank you.
Thank you so much, sir, for this wonderful session. This was really a holistic approach to acute abdomen because you didn't just cover theory but also clinical aspects, especially when you were talking about voluntary and involuntary guarding by distracting the patient and also giving pointers for NEET PG. I'm very sure it was very helpful to all our audiences and to me also personally. So, thank you so much. We have a couple of questions. if you could answer them. The first one is, in the beginning of the session, you mentioned that in acute abdomen, it is always considered like the first thing is it is a surgical cause. But you also mentioned so many medicinal causes that could be involved. So, has there any ever been like misdiagnosis or a case that is very frequently misdiagnosed by junior doctors or maybe medical students?
See, the most commonly misdiagnosed cases in acute abdomen are, see, whenever you have pain in abdomen, you must examine the cardiac assessment and the spine. Most of the time, what happens is there is pain in abdomen because of cardiac and spinal causes, and that is overlooked. You give antacids, you give painkillers, you tell intestinal O. So just if you can remember one thing, I will be very happy. The examination of abdomen is not complete unless you have examined the heart, unless you have examined the spine, and unless you have examined the hernial sites. What happens is patient is complaining of lower abdominal pain. He has a small hernia. He might not be able to tell you he has a swelling. So the examination has to be holistic and complete. Misdiagnosed cases are, but the unfortunate thing is, if you misdiagnose abdominal cases, then there is not a great harm because the pain will persist. But if you may misdiagnose cardiac causes and spinal causes, the harm is more.
Thank you so much, sir. Nandini, any other questions from the audience?
Yes, I have a question. So, one of our participant has an interesting question. What can be the chief causes of an acute abdominal pain in a pregnant woman?
See, in pregnant women, if you are trying to associate with this with pregnancy, then the first and most foremost cause is rupture of ectopic pregnancy, right? And how do you suspect rupture of ectopic pregnancy? A pregnant lady, young, naturally menstruating age, history of amenorrhea, sudden pain in abdomen, and the most important thing is sudden development of anemia. The attendants will tell you, till 2 days back, her eyes were pink, now they are pale. So whenever such a patient comes, you first evaluate whether there is anemia or not, and then try to corroborate whether it is of sudden origin, sudden onset anemia. So going back to your question, in acute abdomen, in a patient who was pregnant, history of pregnancy, sudden abdominal symptoms, right? Especially on the one side of the iliac fossa, one, and then with anemia. Then only thing you have to rule out is ectopic pregnancy rupture, because if you don't diagnose this on the first instance, you will lose the patient because the patient will keep bleeding.
Sir, I have one more question. What are the primary measures taken by the doctor before the diagnosis of cause of an acute abdomen?
See, acute abdomen itself was the full topic for today. So our first cause is we have to evaluate whether this is a non-urgent cause and urgent cause. Number one. Number two, we have to evaluate because this is a surgical cause or a non-surgical cause. Urgent, non-urgent, surgical, non-surgical. If you can decide this as an undergraduate, your job is done. Even if it's a graduate, if you can differentiate between urgent and non-urgent cases, surgical and non-surgical cases, as a graduate doctor, MBBS doctor, your job is done.
Okay, thank you, sir.
So there is one more question by Dr. Tanya. She's asking that she works at a primary healthcare center where she does not have as many facilities or infrastructure as a tertiary care center does. So what can she do to better equip her skills to provide better care for patients and early diagnose such cases?
See, what she can do there is, even if she has an X-ray, or even suppose even there is not an X-ray, she must start examining the patient and taking a detailed history. See, by percussion itself, gas under the diaphragm can be detected. By percussion itself, you can make out whether there is obstruction or not. By percussion and palpation, you can differentiate whether there is peritonitis or not. So, if you are in the periphery, then don't try to be make a specific diagnosis. You may be able to make, you may not make, but you have to there you have to differentiate between the urgent conditions like perforation, like obstruction, right? Like any trauma, hemiperitoneum, or peritonitis. If you can differentiate this, your job is done.
And so one last question from me as a student. Uh, while entering internship, what are things that I should focus on? What are skills that I should focus on acquiring during internship
Very good.
in surgery?
Even in the final year, right now, or even after during your internship, you just emphasize on the history and examination part of it. Rest all will follow. See, ultrasound findings, you can Google them. But what you have to inspect by your hands, no Google can teach you. That you have to make out. You go in the wards, see as many patients as you can. If you don't find patients, come to me. I will tell you patients.
Thank you so much, sir, for this wonderful session, Nandini.
Thank you so much.
Now, I guess it's time for vote of thanks. I want to extend my sincere thanks for joining us today in this crucial webinar on abdominal emergencies. I would like to thank Sir Dr. K.K. Singh. It was pleasure to be in this seminar. I would like to express my appreciation to engaged participants and the organizing team for making this event a success. Let's remember the importance of the knowledge shared here today. Thank you once again for your active involvement. Stay connected for future events, and until then, continue your valuable work in the field of healthcare. Goodbye, and it's all for the evening. Good evening.
Thank you. Thank you.
Thank you so much, sir.